I'm originally from Florida, Miami, Florida. I went to University of Florida for my undergraduate. I majored in biology, and then from there, I went over to Virginia Commonwealth University in Richmond, Virginia, where I did my medical school, and that was awesome. And then from there, I went over to the University of Oklahoma in Tulsa, Oklahoma, and that's where I completed my family medicine residency training. I graduated residency in 2020. So it's been a few years. Right after residency, I pretty much started working in that family medicine department at the University of Oklahoma in Tulsa as one of the core faculty in the residency program, mainly doing outpatient clinic work and precepting residents and all sorts of teaching responsibilities and academia. And then from there, I made my way back to Florida and found myself at University of Central Florida. It's going to be 3 years this summer since I joined UCF, College of Medicine. So yeah, it's been an awesome trip, but I'm here. So I have a bit more of a interesting, I guess, pathway to primary care. I originally was very interested in obstetrics and gynecology, and that's what I thought I was going to do. I was so set on it in medical school. I did all my sub-Is, my acting internships, everything. I applied. And I actually ended up soaping into family medicine, which actually ended up being quite a blessing because I realized that, well, number one, I did not want to be a surgeon. Um, and that's kind of a big part of OBGYN, of course. And I just realized that what I had really enjoyed about obstetrics and gynecology was kind of the primary care aspects where you're focusing on women's health, but you're also doing a lot of preventive care. Um, so I found that I still get to do a lot of those things, but then my scope is now a lot more broad. My training's a lot more all-encompassing. I found that that's really what I wanted to do. And it ended up being a blessing in disguise because I don't think I would have been very happy being a surgeon or delivering babies at 3 a.m. And, we'll talk about how, of course, with primary care, you can do those things if you want to later on. But for me personally, it was the best move because I got to do what I loved without having to stress myself out doing things that I realized I didn't really want to do long term. My first job out of residency, I was core faculty in a residency program. So I was in charge of the academic afternoons and the academic didactics curriculum for our residency program, which was a bit of a daunting task, arranging for, board prep and, guest speakers and basically our whole academic afternoons. So that was a big part of what I did. I also was on certain committees, working to help evaluate the residents and for promotion and all that. That was kind of a lot of what I was doing over when I was working in my previous job. Here at University of Central Florida, I've done a lot more, just working in the clinic. I'll kind of tell you more about our how our clinic is and how it's a little bit special. But from a working as a primary care provider in a clinic, that is in and of itself a bit of a leadership role where you have a lot of other medical personnel that are working, with you, and you are kind of having to, make some decisions on a day-to-day basis that is, leadership based. Officially, from the university standpoint, I don't have like a big leadership role as of yet. I'm still pretty early on in my career. But yeah, no, I'm always open to new opportunities and hoping to grow in that area. So it's usually when you're starting off in a new job, getting your feet wet, building your patient base and all of that. But it's been good. There's a lot of opportunities at UCF in primary care, especially. We are very poised for being great leaders. We tend to know how to um, function in a lot of different types of medical teams. And, as a physician in any capacity, in any setting, you're going to be in a somewhat of a leadership style role. So, yeah, I'm not very fancy right now, but hopefully someday I'll be fancy. Currently, I'm practicing at the Osceola County Employee Health Center. It's actually a clinic called Mind Health On-Site. So that's more of a corporate clinic that has locations throughout Florida. Their clients are, the Osceola County, the sheriff's office, the tax collector's office. So we are basically providing care for um, employer-sponsored care, more importantly, to the employees of the county, the tax collector's office, and the sheriff's office for Osceola. So through my role with UCF, we're pretty much contracted out to work for that clinic. But we are employed by University of Central Florida. So there's a bit of teaching and academics involved in our responsibilities as well. We welcome students, from the university to rotate with us. We're one of the sites for the third year rotations. Um, and I'm also a preceptor for COP 1 and 2. So we tend to get all levels of students that rotate through with us, just to kind of learn more about the different practice, environments. Our clinic is a little special because, like I mentioned, it's employer sponsored. So our patients, they don't pay anything out of pocket for our services. They have their own private insurance. I believe this year's through Cigna, but they have their own private insurance that they use to access care outside of our clinic, so specialist offices or anything they need to do outside. But everything we provide is covered through the clinic and basically through their employer. So it's a big cost savings for the patients. They love it. They greatly appreciate it. So the practice model is a bit different as well, since it's a little bit less. We're not like RVU based, so we don't bill based off of those RVU credits. And it's just a very interesting model because it also saves the employer because we're able to manage and head off a lot of you know problems early on. It's a very preventive model, so that hopefully they're not having to then go use their insurance and spend all that money through the insurance for problems that occur later on that we could have handled earlier on. I really love the fact that it's not super. I mean, we have to meet certain metrics and everything still, and make sure everyone's happy, but it's not. They don't really push us to be like, you got to see a patient every single 10 minutes, and if you don't see a patient in that 10 minutes, that's money lost. Like that's not the philosophy behind it. We're really able to spend time with our patients and get to know them. I know that other places I've rotated at or practiced at or whatever, a lot of times their office visits are 10, maybe 15, 20 minutes at most. You really don't get a lot of face time with the doctor. It's pretty abbreviated. Um, with our clinic, a new patient appointment can be 40 minutes. A physical can be 40 minutes. That's a pretty big luxury, unless you own your own practice and make your own rules. But considering we work for someone else, that's actually pretty awesome. So I really just love being able to take my time within reason to get to know my patients and to really make them feel like we're listening to them and that we're trying to be as comprehensive as possible. So it does build a great deal of trust between us and the patients over time, where maybe if they still go see other doctors for specialists for other things, but then they always come back to us, and they're very appreciative for us working to kind of help coordinate their care as primary care. So I think that's very rewarding, is just getting to know the patients and having that continuity, because it's very easy with our clinic because they don't have to pay to see us, so they actually are you know pretty happy about coming to see us. Yeah, so I mean, every day is a bit different. That's the beauty of primary care, is that you're never quite sure what the mix of patients is going to be because you see such a variety. But I would say on an average day, like an 8 to 5 day, I would personally, I said I would see probably anywhere between 12 to 15 patients, sometimes a little, maybe plus or minus a little more, just depending on if I overbook myself or if there's something extra tagged on. But I would say about 12 to 15 is average. Um, I usually go, a morning session and then get about an hour for lunch. I'm usually doing different tasks during lunch because I'm just can't sit still. But then the afternoon session after that, the mix of patients can be anything from annual wellness physicals, well woman exams, which includes like pap smears and all that type of stuff, medication refills, lab reviews. So people who have their labs done, we can go over their results with them. Sick visits, that's pretty common. So people who are coming in with a specific complaint, they hurt their shoulder, they have a cold, usually, not super life-threatening, complaints. They'll have the occasional, oh gosh, I'm having chest pain, and then you have a bit more of an emergency and you might be calling the ambulance, but those are few and far between for us. They happen occasionally, but not very often. Um, and then procedures. It usually depends on what you're comfortable with. So I know, like for myself, personally, sometimes we'll do like cryotherapy. We'll freeze some stuff off. We can do biopsies, minor skin biopsies. Uh, One of the ones that we can do at our clinic is like IUD removals. Those are pretty simple. We can't currently insert LARC, so IUDs and Nexplanons, but as a family medicine provider, you will be trained to do that. And depending on where you're practicing and what their capabilities are, you may or may not be able to perform those procedures. Um, you can do joint injections, different types depending on your training. One of our nurse practitioners, she is trained to do PRP, so special types of injections. But myself and some of my other colleagues, we don't do that one. So it just depends on how much you want to keep up with certain procedures and what your comfort level is. As family medicine, you can really get trained in doing all sorts of things. Some people do just simple laceration repairs. Some people feel more comfortable with, more complex ones. I mean, I don't do a lot of laceration repairs in my clinic, but I do take out a lot of sutures. Uh, so it's very varied. And then, of course, there's admin things that you have to do as physicians where we have to carve out some time to make sure we're getting our refills done, making phone calls, paperwork. If we have some paperwork we have to fill out for patients, meetings, all the fun stuff. So I say every day is a little different because it just depends on the mix of patients you're going to see that day. You might have a day where it's a lot of annual physicals and you're like, oh my God, if I have to do one more physical. Or you might be just a day of very sick people because it's flu season and everyone has the flu. I would say at our clinic, it's mostly adults. We do see children from time to time, um, but it's primarily adults. And our clinic is also a bit more unique in the sense that we don't tend to see too many very elderly folks. So I would say usually around 65 or so, we don't have too many patients at that age or above. Mainly because for us, since we're employer-sponsored clinic, a lot of those folks end up retiring around that age, and then they don't keep the insurance from the employer. They go on to Medicare, Medicaid, whatever. So our demographic is a little bit different than you might see in some other primary care clinics. So that also changes the variety of things that we see. I think it's just the gratitude from the patients, honestly. Like I said, we were able to really, get to know our patients, and I can't tell you. I mean, I have hard days, where we feel overwhelmed or we're just like, oh, we're so stressed, there's so much going on. But there are days when I'll have patients that just tell me like how thankful they are for, the care, the time, the, attention that we've given them. And they really truly do feel heard and seen. And I think, I mean, as someone myself who I've had to navigate the healthcare system with my own doctors and everything for other reasons, I think that's something that when you find people that listen to you and, it's not that common. But I think that's what keeps me going. It's just hearing back from patients that they're just so grateful for what we're doing for them, even if it seems small to us, and we're like, that's literally just my job. Um, but it feels good to make that kind of difference and that kind of lasting impression on a patient. So, I I very much am a work to live, not a live to work kind of person. You'll see many different types of personalities in medicine where there are some people that, being a doctor is their whole personality, it's their whole lives, it's their passion, it's everything about them. And that's great. I love that. For me, I like to have more of a balance between my work and my life and being able to be working outpatient care. It really allows me to focus when I'm at work that I'm working really hard. You know, doing everything in my power to be the best at my job. And when I come home, yes, sometimes I bring home some work here and there, but it's not an overwhelming amount. And I'm not on call. I'm not having to race to the hospital to, you know, go admit patients or do whatever it is at the hospital. So for me, it just allows me to be present when I'm at work and when I'm at home, as long as I've, completed everything I need to, or there's nothing like critical or urgent that I get called about, after hours, which rarely happens, but there's nothing critical I have to be doing and it's just a regular day. I really get to then focus on, you know, de-stressing, relaxing, doing other things with my time. So that work-life balance, I think, really works out well for me for outpatient primary care. And you'll have different jobs that they have different requirements. There are some primary care practices that do require you to take a certain amount of call, that could be more or less busy, per month, per year, whatever. Some practices admit their own patients to the hospital. Some practices do home visits. Some people have weekend hours. That's just part of, whatever contract or whatever job it is that you have. But I just feel very fortunate that the job that I have right now is, very supportive of a good work-life balance. There's a lot of considerations when it comes to choosing a specialty, right? I will say that there are lots of primary care jobs out there that will pay you a lot more depending on what a setting you're willing to practice in. More rural jobs where they're more desperately seeking primary care physicians who kind of can do it all and see it all for like a very underserved population. Sometimes they will pay you more money to go out there and work. There's different types of contracts. Or if you do more hours or you're doing inpatient and outpatient, there's all sorts of different practice settings or ER even. There are a lot of family practice folks that end up going to practice like in rural ERs. So they get paid a lot of money to do that because there's a big need. So I would say your compensation really just depends on, like I said, what kind of where in the country, where in the world you want to be practicing, what kind of setting you're going to practice in, if you're going to be private practice, corporate, uh, private practice, academia. They all have different kind of pay scales, depending on also like the billing model. So some places, a lot of places, most places, I will say, they bill according to you get compensated a certain number of revenue units based off of the complexity, the level of what you bill, the procedures that you bill for, X, Y, and Z. And then you get compensated depending on, differently depending on what insurance you're billing. So, people who tend to have a greater grasp and understanding on, how billing works and how they can, uh, maximize their compensation for the work that they're actually doing. Because we do a lot of work as primary care, but we're notorious for not billing to the level that is actually appropriate for whatever reason, because some of us just don't understand billing as well. But those that do can benefit from that, uh, for sure. So I would say that, I mean, the numbers it's pretty variable. I've heard of primary care doctors making somewhere in the ballpark of like 300K or something like that. I've heard them making in the upper 100Ks. Like there's a big range. I would say yes, if you're going to look at primary care versus maybe a more lucrative specialty like a surgical subspecialty or something where you're going to be making many times, that money. It really just depends, all of us, well, not all of us, but a lot of us have student loans, or there's certain programs that we participate in because we're looking for ways to help ease that loan burden. That is also something to take into consideration. There's those programs, like the public service loan forgiveness programs, that's kind of been in flux lately. So, a lot of people have finances to take into consideration. But I would say, in primary care, you're probably not going to like go drive a Maserati Lamborghini out the gate and, live in a mansion unless you already have some money. But at the end of the day, we live pretty comfortable lives. And as long as you manage your finances well, like you're not going to be hurting for money. So it really just depends on what your goals are. If you're very much like I want to make as much money as possible, then, maybe that'll play into your choices, and there's nothing wrong with that. But I would say for most primary care, it's definitely a manageable thing. And for me, like I said, I'm very much like I like my work-life balance. To me, it doesn't matter so much if I make X amount of money more, like my mental well-being, my peace kind of matters a bit more to me. So that it just what your priorities are. Everyone's a little different, but we're doing okay. I think the future of primary care, I foresee that there's going to be a lot more adaptation of, great technologies that are going to hopefully help ease the burdens that we're experiencing as primary care providers. I think, you know, there's more advancements in the use of AI and whatnot to help with things like documentations, chartings, things like that. I personally haven't fully embraced that yet. Maybe I should. But I think there's a lot of things down the pipeline that are hopefully going to help ease some of that burden because I think one of the things in medicine in general, not just for primary care, is just making sure that we're taking care of the people who are in the profession so that we're not burning out, so much. But I think in general, it really just depends on what regions you're in because I've noticed a big difference in working in somewhere that was a bit more, I wouldn't say rural, but where family practice does a lot more, versus kind of coming back to the East Coast where there's a lot of people who don't even really know what family practice does. Everything gets shipped off to the specialist, or it's just an internist, a pediatrician, and then all the specialists. And they're like, well, what's family practice? We don't even know what that is. So like regionally in the country, there's all these different attitudes or levels of knowledge about what family practice is. But I think there's a lot more awareness now. So I think going into the future, a lot of hopefully our future doctors will consider going into family practice to help bridge some of those gaps in care that we're seeing in a lot of parts of the country because we really are poised and trained to really provide, at least a base level of good quality evidence-based care to pretty much anyone. I mean, we do newborns to geriatrics. There's people who are family practice who are subspecialized. I'm hoping that's actually something that I think in the future is going to become more. There's going to be more fellowships, I hope, for family practice providers who want to kind of do a little bit more specialization. Because in the beginning, there was just maybe like sports medicine and OB. And now there's lots of other fellowships that are popping up. So we have people who are doing wilderness medicine or obesity medicine, lifestyle medicine. There's all these little, niches. So I just hope that, there's more passion. And I hope that students in the future can really realize that family medicine is a really good, strong, solid foundation that you can use as a backbone to then blossom into whatever kind of doctor you want to be. I think a piece of advice that I try to give any medical student, whether it's primary care or if they're interested in any specialty, is that when you're approaching your training, just have an attitude, an open attitude, and a curious attitude, because it doesn't matter if you're not interested in this specialty. You're like, I'm never going to be, a surgeon, or I'm never going to be a pulmonologist or whatever. Like, take whatever you can out of that rotation. Just absorb as much as possible because you just never know. Like, it might be the last time you're exposed to that. Maybe that one thing you learned from your surgery rotation is going to save you in a different rotation, or years in the future when you're attending, you're like, I remember I learned that one thing from that one rotation. So I just tell people, like, when you go on a rotation, just pretend like you're that kind of doctor for like that many weeks, and just really dive in because it's the only time in your training, I mean, aside from residency, if you do family medicine, you'll get to rotate through a lot of those again. But even for my medicine residents, I always tell them, just try and like absorb everything that you can from these rotations, or at least pick a few things that you're going to take with you into the future, because you just never know. As a family practice provider, you're essentially supposed to be, a jack of all trades. You kind of have a very wide breadth of knowledge. We're not expected to know everything about everything, but just enough so that we know, how much can I manage? What do I feel comfortable managing? At what point do I need to get this person to the correct, higher level of care, or, certain specialist, or whatnot. So I just think it's just so valuable. And I think people tend to sometimes say, oh, it's just primary care. All they do is, look at people's stubbed toes and colds and coughs. But you'd be surprised. We sometimes deal with very complex patients, and it's our jobs to really coordinate care for them, just help fill those gaps. Sometimes, just keep them alive until we can get them to see, the surgeon or the specialist or whatever. So it's just pulling on that breadth of knowledge. So just stay curious, stay open-minded, never lose your empathy. I think that's kind of a big thing. It's even on your hard days, as long as you can empathize with patients and you can, understand where they're coming from, that's really going to help pull you through some really, really hard situations as you go through your training. So yeah, I think that would be my biggest advice. It's a lot of advice, but you know, medicine's a marathon, not a sprint. So I just wish everyone the best of luck in everything. And, if anyone ever has any questions about family medicine or what it's like being primary care, I mean, you guys know how to find us.